Again, welcome to today's session. This is a statewide anesthesia and critical care seminar, dubbed SWACCS, brought to you by the Anesthesia Society and the Intensive Care Society of Uganda's AAU and Intensive Care Society ICSU. We have been here before, and that is starting last week. We resumed with Pulmonary Madness, which is really introducing us to the lung in critical care medicine. The idea here is that we need to learn something new together, and the target being to raise awareness of the power within each one of us to intervene and help patients and to tool us with other clinicians, on top of inspiring those who are not yet in critical care medicine into a career in critical care medicine. Very fulfilling, sweet moments for patients and make them better. So you're all welcome previously on this platform. We welcomed you back because it had been 2 years of silence, and we had quite a good session introducing the Pulmonary Madness. We had lung in motion, which was really basics of lung physiology in health and in critical illness, as well as mechanical ventilation. That was the team that presented was mentored by myself, Erasmus Okello. And in terms of the topics we covered, we had quite an array of topics. That was, first one was respiratory system basics, presented by Dr. Sophia Namoviru, followed by Dr. Sheikh, who took us through ventilation perfusion relations. And then we had mechanics of ventilation, mechanics of breathing, presented by Dr. Kemi Kishaya Simwe. And finally, when you guys were seemingly tired and you thought it was all done, we had quite a beautiful serving of all stuff relevant to mechanical ventilation physiology by Dr. Fred Nsereko. You can find this on this particular link, which I'll share on the chat, just in case you are joining us for the first time this time around. You can get a catch up later by copying and saving this link. And be sure to subscribe to the AAU YouTube channel so that you can access some of the recordings that you missed. Some of them go way back to the previous time when we were running this show, as well as other relevant conversations we've had as a society that may not necessarily be related to SWACCS or critical care. Today, we go to episode 2, and in this case, we're tackling hypoxemic respiratory failure. And this session is going to be mentored by by Professor Arthur Kwizera, who hopefully will be joining us in a bit, and myself and Dr. Cornelius will be moderating. We've got 4 presentations, and I'll run through them quickly. First, we shall have the clinical case presented by Dr. Emmanuel, and then we shall have a bit of an overview on ARDS, which is quite a hallmark or representative disease in hypoxemic respiratory failure. Then we shall go into the physiological approach to management of hypoxemic respiratory failure, using ARDS perhaps as a guide, but also the freedom is to the presenter as well as her mentor to determine what they want to do. And then we shall conclude with a discussion on the cardiorespiratory effects of prone ventilation. I mean, in our setting, this seems to be, your go-to final card in case a patient is not doing very well. And the question is whether we should do it as a final card or we can do it much earlier. So without further ado, I'd like to retire my slides and have Dr. Emmanuel Emo present project slides. He is a 3rd-year resident in anesthesia and critical care, and he's going to present to us a clinical case that will guide our conversation today. So over to you, Dr. Emo. Kindly project your slides, Dr. Emo. Start off right away. All presenters have about about 20 minutes to present, and then save time for conversations. Our hope, as before, is that we get out of here in 2 hours. We've lost 15 minutes already. So here you go. Start, Dr. Emo. Thank you. Bye-bye.
Thank you so much. I hope everyone can hear me. Good evening, everyone. So I'm bringing for us a case of patient with ARDS. My name is Emmanuel, as introduced earlier. My patient is a KRA who is a 56-year-old female. She was admitted on 27th of November last year at TMR International Hospital. She spent about 26 days with us and was discharged on 22nd of December. She was morbidly obese. I think the 100 is an estimate, but she could be even higher than that. So she was a known patient of hypertension. Prior to the transfer to TMR, was admitted to UMC Victoria with several days history of non-productive cough associated with difficulty in breathing and low saturations. She also had fevers, generalized body aches, and hypotension. At her admission, she was diagnosed with severe ARDS and subsequently taken to ICU and intubated for respiratory support. During her stay in the ICU, she got septic. In fact, picked her up in septic shock, had AKI with a raised creatinine of 601 micromoles per liter and urea of 24.6 millimoles per liter. At the time of the referral, she was on 3 antibiotics, linezolid, meropenem, oxfloxacin, and a steroid, dexamethasone, about I think 8 milligrams 12 hourly, and was on vasopressors, as vasopressin and noradrenaline. How she was receiving them was quite tricky to quantify the support, the quantity of final support she was getting. So the day she got transferred to TMR was her 5th day in ICU. That was on the 27th. We took her in under sedation, transferred, intubated, and on mechanical ventilation all the way from UMC to TMR on PRV-CSI-NV mode with a PEEP of 10, pressure support of 30, at an FiO2 of 80%, with tidal volumes of 450 sed. At admission, what we started managing was a severe ARDS. She was also diagnosed with a massive pulmonary embolus during the course of her stay. AKI, she was fluid overloaded and had a hemorrhagic stroke, slightly small, but we owed it to possibly therapeutic dosing of Clexane because of the PE that was diagnosed. During the transport and settling her into the ICU at TMR, we kept her sedated. She was on meropenem and linezolid plus moxifloxacin, but upon transfer, we continued with only meropenem and linezolid, dexamethasone, weaned off vasopressin and continued with noradrenaline and continued bosentan. We also initiated paralysis with rocuronium and started fluid restriction. Started diuretics shortly after arrival, acetosemide, metolazone, spironolactone. Cultures were taken, blood culture and urine. We did RFTs and extended electrolytes and ABG. We paused anticoagulation in view of the bleed in the brain. On day 2, she was proned, continued fluid conservative strategy with diuretics PRN. However, the AKI seemed to be worsening. She became oliguric. We maintained dexamethasone, continued bronchopulmonary toilet. We titrated a PEEP to achieve adequate oxygenation and maintain bosentan. At day 3, she was still prone and paralyzed, but became anuric. At this point, we had full-blown anasarca. In the respiratory system, we had crepitations throughout the lungs. Still on the same mode, PRV-CSIMV, PEEP of 8, pressure support 30. We only managed to go down on the FiO2 from 80 to 60. The tidal volume was 460, respiratory rate of 25, and we were managing SpO2s of above 92. By day 4, the decision was made to dialyze the patient. Her creatinine had risen to 7.4 milligrams per deciliter and urea 325. We took her for SLED, a 6-hour session, filtering 3 liters of fluid, 4 hours of hemofiltration, and 2 hours of hemodialysis. We did it under anticoagulation. This was now 3 days after the brain bleed, and ran the whole session under noradrenaline. Post-dialysis, we kept her on the same mode, and the support remained largely the same throughout the rest of that day. She still had crepitations in her lungs, maintained paralysis, but we didn't prone her upon return. Day 5, she was proned again for another 18 hours. We stepped down on sedation, removed fentanyl, and continued with midazolam and rocuronium. She hadn't had any bowel movements from the time she was admitted to the unit and several days while she was in the referring unit. So we started her, we held enterophils and started her on carbaven. That day her vitals were fairly normal. BPs were 154/76 on noradrenaline, 0.1 micrograms per kg an hour. This dose was being tapered. She came in at higher doses or requirements of noradrenaline. This was an improvement. Our respiratory rate was between 25 and 27. She was starting to make some breaths despite the paralysis. Her temperature was 35.7, and she was on this day achieving high SATs above 96. Mode of ventilation was still PRV-CSIMV. Tidal volume set was 460 at a rate of 25 breaths a minute. We'd managed to step down the FiO2 to 34. PEEP went up slightly to 10. Pressure support came down to 20, down from 30. She still had crackles and bloody aspirates. The plan was to remain fluid conservative, paralyzed, and then keep her prone for at least 18 hours, and then maintain bronchopulmonary toilet. Key events from that day on. Initially, we thought we would have at least several consecutive sessions of dialysis, but upon assessment after the first session, we started to note some improvement. By day 7, urine output was still good. We maintained diuretics. We managed to switch to CPAP with a PEEP of 9, pressure support down to 16, FiO2 30. No paralysis at this point. She was making 22 to 23 breaths a minute, and she was achieving SpO2s 98 and above. Day 10, she was extubated. During that time after extubation, she was doing quite fine, respiratory rate of 24 on nasal prongs at 3 liters per minute of oxygen. She had minimal basal crepitations, but her SATs were good, 98%. 2 days later, we had a failed extubation. She had copious secretions, but with poor effort in managing to cough and clear out the secretions. So she was reintubated and put back on PRV-CSIMV with a tidal volume of 460, FiO2 at 100%, which was eventually tapered throughout the course of that day. Kept a PEEP of 7, pressure support of 10. She didn't need much of it. It was just weakness. Her SATs were really good. For that day, she wasn't paralyzed. Started weaning dexamethasone, and by then physiotherapy was already ongoing, so it was maintained. This is basically a summary of trends of her RFT is mostly creatinine urea, and then the ventilatory support that she'd received over the days and the changes that happened. So day one, from the day she arrived to the unit, creatinine largely kept going up. Same thing with urea. This is the day dialysis was done. And these are on here, day 5. The values here are post-dialysis, 6 hours post-dialysis when these tests were taken. And you can see that the support in the respiratory support we were giving her had started going down. We brought her back in still on PRV-CSIMV mode. PEEP was 10. The pressure support stepped down from 30 to 20. FiO2 were able to put down from 60s to 34. The following day, generally, creatinine kept trending downwards. Urea didn't change so much, but there was improvement, and she was making good urine volumes with diuretics, and she didn't require any other sessions of dialysis after this point. Day 7 was when we started her fully on CPAP, and by day 10 is when the first extubation was made, and she did well. Only failed because of weakness, failed to clear out secretions. So reintubated on the 12th day, put on PRV-CSIMV mode. Still, the support wasn't so big. Even the FiO2 was tapered during the course of the day to 30s. By the 13th day, we put her on CPAP, tried the Swedish nose, and she was doing well. Subsequently continued on the Swedish nose until we finally extubated her on day 17, and she did very well. Here she was, by day 17 after extubation, the support was only 2 liters of oxygen by nasoprongs. She progressed well, improved, continued antibiotics until septic markers were all fine. Day 26, she was discharged home, and these were her labs, especially urea creatinine, on the day of discharge. Basically, that's the patient presented to you. Thank you. Any questions?
Right. Yes, thank you so much, Dr. Emu. We do have a number of questions on the chat that we're going to go through quickly. Yeah, maybe just a few things on the presentation. Of course, we don't have the images from the imaging studies of the patient that will be helped to get a better picture of what we're dealing with.
And also, unfortunately, I couldn't retrieve them. I made this presentation after the patient was discharged. Usually, they go with their images. Okay. I should have followed up with the radiology. I think they could have had copies. Sorry on that. Skipped my mind.
Also, regarding the modes, perhaps the vent mode on spontaneous on day 7 actually is pressure support ventilation, not CPAP. Most ventilators come with that one button that says CPAP stroke pressure support ventilation. but it's actually a PSV because you set a pressure support then to support a patient. So at best, you can say CPAP stroke support. So over to the questions right away. First question is from Dr. Mary MJ. Says, what was the rationale of using 3 diuretics? Otemo?
Well, the patient, okay, she was already on 1 diuretic at the time she was referred to TMR, and urine output was poor. So adding more than 1 diuretic was to help increase the urine output. On the choice of the diuretics is, I think, for the effects of electrolytes, especially something like spironolactone for the potassium sparing effect. Yeah, but on the number of the different classes, I think it was to improve urine output of the patient. But unfortunately, she still progressively dwindled in urine output to the point of requiring dialysis. That's my.
Yeah, sure. So the patient came on furosemide already, and then added in metolazone, which is a thiazide diuretic to block the distal convoluted tubule, as well as spironolactone to spare potassium and improve the urine output or diuretic effect of furosemide, so that hopefully that will help with fluid management. Remember, the primary renal complication we're dealing with at the time is fluid overload, which was building up a lot over the preceding days that the patient not passed urine. And so the hope was that by using the 3 diuretics would hopefully improve the urine output high enough to avert the need for dialysis and the like. Unfortunately, as you mentioned, end up on dialysis. Okay, next question here is, how was the bronchopulmonary toilet done?
This patient was transferred in intubated, so we maintained the ETT in. TMR is a privileged institution, I guess. There is closed suction. Basically, pass down the catheter, powered by the suction machine. We suck out the secretions in the airway. Largely, that is what was done.
Perhaps on that, top of that, with closed suction, because it accompanied with the chest physiotherapy, chest percussion, and positioning for postural drainage, just to optimize the removal of fluid. That is on top of adding things like mucolytics, just to improve the removal of mucus. I'll ask Dr. Preach. Dr. Preach Kagera is going to ask that question. He's an intensivist and has been part of us, currently doing this work somewhere in the UK. And he will probably give us a bit more of an idea of what he would do in a similar situation. If there's anything else that we do. Certainly, we did not do bronchoscopy in this case. The patient's secretions were well managed with just a good old time suctioning. And the secretions are not extremely that horribly thick for the most part. Next question is from Semakula Jonathan, says, pressure support of 16, PEEP of 9. How did you come up with a decision to extubate? I guess I'll just take this one quickly so that we save a bit of time. The pressure support of 16 and PEEP of 9 merely cross-sectional numbers that the presenter picked up from the patient's profile, but certainly the patient was progressively weaned to pressure support of 5, PEEP of 5 in this particular case. FIT requirements were 30 or less, and saturating fine, breathing quite fine. RSBI was quite good, and so the patient was extubated and initially did quite well for some time before progressively getting weaker and deteriorating. And the primary reason was that she was accumulating secretions in her airway due to a poor cough impulse due to the I guess, critical illness, associated weakness, perhaps partly because of the illness itself, but also partly due to the steroids and paralytic she had been getting before. All those might have contributed. And Mosarina is asking, apart from CTPA, which showed PE, is there a role of doing X-rays for the progress of ARDS? I would like to leave this question for the next presenter, Dr. Moses Arinaitwe. That will be that will be covered later. And then finally, Dr. Preach Kagera is asking, did any cultures come back? So yes, we had the patient culture, Klebsiella pneumoniae, which was multi-drug resistant, actually, except that it's sensitive to carbapenem, yes, which we used for her care. And these were found in the tracheal aspirates. They were found in tracheal aspirates as well as urine. And these cultures rhymed with the cultures we found that were captured in the previous admission, and in the first hospital she was admitted to, that was UMC Victoria. So just repeat the cultures on arrival. Yeah, so Dr. Preach, as Dr. Emu retires his slides, I would like to just ask of you, in your experience, what you guys would do for bronchopulmonary toilet. And we get the next presenter projecting the slides in a moment. So Dr. Preach, over to you.
Thank you very much, Dr. Okello. And well done. You managed this patient very well, and she was able to pull through. Well, for bronchopulmonary toilet, I must say we are privileged to have the ability to do fiber optic bronchoscopy, and it really helps to look for the mucus plugs. However, as you have said, if you do chest physiotherapy, chest percussion with mere suctioning, you can actually get a lot of the stuff. It's just that sometimes we have difficult mucus plugs. For example, in the right upper lobe, it's a bit difficult, and that's where fiber optic bronchoscopy can be very good. However, chest physiotherapy is the most important thing. And then with the inline suctioning, that one also works. But well done. Thank you.
Thank you very much. Yeah, absolutely agree. We have capabilities for fiber optic bronchoscopy, which we do especially if clearly the patient's burden of sputum is the kind that we will not be able to clear with just regular stuff, regular suctioning and chest physio. And we've occasionally done that. This one, unfortunately, was not in that category, and we were able to pull through the less technological advanced measures. All right, thank you very much. Now, without further ado, I would like to welcome the next presenter. Dr. Daniel Waiswa is a resident near to anesthesia and critical care. And he's going to take us through the overview of ARDS. Again, as we've done here, kindly share your questions on the chat, and keep your mics muted until we call for questions. Thank you. Dr. Daniel, over to you. So Dr. Daniel, we'll try to run this again in about 20 minutes or so, and then we shall save time for questions.
Okay. Good evening, everyone. I'll be taking you through ARDS. Hope everyone can hear me. So objectives of this presentation, we'll look at the introduction, precipitating factors or causative factors, criteria for both adults and children, pathogenesis, the clinical course, some investigations, differentials for ARDS, management options, complications, and I'll conclude with brief references. So to begin with, ARDS is an acute diffuse inflammatory lung injury, which can be precipitated by a number of factors. It is a life-threatening condition which accounts to about 10% of global ICU admissions. And it is important to note that timely identification and intervention is very critical in trying to improve the survival chances of a patient with ARDS. So looking at the Uganda perspective, prevalence of ARDS among mechanically ventilated patients was higher than that reported in high-income countries. ARDS-related mortality was also noted to be higher despite the younger age of the patients. That's from research done by Professor Arthur Kwizera et al. 2022. There was also little evidence of ARDS management practice in Uganda. That's something to note. So among the predisposing factors or causative factors, we'll have pneumonia, we'll have sepsis, we'll have trauma, we'll have transfusion, burns, aspiration, shock, smoke inhalation. It can also arise from drug toxicity or secondary to patients who have had cardiothoracic surgery as a sequelae, or in patients who have had hematopoietic stem cell transplant. So we go on to try and look at the criteria as that can apply to all age groups. The risk factors and origin of the edema. This can be precipitated by an acute predisposing factor, the pulmonary edema, plus the predisposing risk factor. The timing, when you're talking of ARDS, we need to note that it should be of an acute onset, or we could have worsening hypoxemic respiratory failure, which should be within 1 week of estimated onset of the predisposing risk factor. New, or if you look at the imaging, we should have bilateral opacities on chest radiography or CT, or if we use ultrasound sonography, we should have bilateral B lines or consolidation on ultrasound. But this should be by someone who's experienced in ultrasound. And these findings should not be explained or not be fully explained by pleural effusions, like atelectasis, or nodules or masses. So going forward, we find that when you're looking at ARDS, the criteria, some of the criteria that you're based on to classify or to make a decision as to whether the patient has ARDS, there are different settings that would help you. If you're in a resource-limited setting whereby you only exposed, what you can be able to use is SpO2, your cutoff would be FiO2 of less than 315, with that's SpO2 dropping less than 97% of oxygen saturation, where you have neither PEEP or a minimum flow rate oxygen required for diagnosis in a resource-limited setting. So when you go ahead to a patient who's not intubated, we look at two parameters. We look at the PaO2 FiO2 ratio. In this, if you get the ratio less than 300 millimeters of mercury, or the SpO2 FiO2 ratio less than 315, in a patient whose saturation is less than 97 with high flow nasal cannula at a flow rate of 30 liters per minute, or non-invasive ventilation or CPAP of at least 5 centimeters of water and expiratory pressure. So if we look at the oxygenation criteria to apply if we're looking for ARDS in intubated patients, here we'll look at 3 criteria where we can divide them into mild, moderate, severe. To say that if a patient has mild ARDS, we look at the PaO2 FiO2 ratio. For the mild, the ratio should be greater than 200 millimeters of mercury, but less than 300 millimeters of mercury. On vent settings that include a PEEP or CPAP with greater than 5 centimeters of water. Alternatively, it can be a SpO2 FiO2 ratio greater than 235 but less than 315 millimeters of mercury. If the patient is saturating less than 97%. Then for moderate, we'll consider this if a patient's, if the PA FiO2 ratio, if the patient is, the ratio is more than 100 but less than 200 on vent settings with a PEEP of more than 5 centimeters of mercury. Alternatively, if you're considering SpO2 FiO2 ratio, it will be a ratio whereby the patient has a reading of more than 148, but less than 235. If the SpO2 is less than 97. Then if for a severe form, you'd find that for the PaO2 and FiO2 ratio, we'll consider this if the patient's reading is less than 100 millimeters of mercury, or if you're looking at SpO2, if it's less than 148. So this was got from the American Journal of Respiratory and Critical Care Medicine. So this criteria goes on to look at other parameters where you can look at age groups. So if you're looking at pediatrics, all age groups, except patients with perinatal lung-related disease, are considered. Timing, in timing, we look at the onset of hypoxemia. The radiological changes should be within 7 days after a known clinical insult. Chest radiographs, here we look at presence of new infiltrates consistent with parenchymal lung disease, even if unilateral. This is something to note in children. It can be unilateral. Oxygenation, that will be on the next page. And then there are special populations, if you're looking at pediatrics for ARDS, patients who have cyanotic heart disease, chronic lung disease, and left ventricular dysfunction are also now included if they have acute deterioration of these symptoms, which occurs but can't be explained by their diagnosis. To further expound on oxygenation, we look at the definition of hypoxemia. For invasive ventilation, we look at the oxygenation index, which will look at the FiO2 times the mean airway pressure times 100 over the partial pressure of arterial oxygen, or oxygen saturation index, which is equal to FiO2 times the mean airway pressure over the SpO2. Then for non-invasive ventilation, where we have a minimum CPAP of 5 centimeters of water, we look at a PaO2 FiO2 of less than 300 or SpO2 FiO2 less than 264. We should note that both scores were consistent in designating patients with severe ARDS, but the oxygenation index was more accurate. So if you're looking at ARDS, we have looked at the criteria, we'll go ahead with investigations. It is very important to always consider the history and physical examination. This will help you sieve through the differential diagnosis as when you're looking at ARDS. So history. What's important to note in ARDS is that our history, we should have history of dyspnea or reduction in oxygen saturations that occurs 6 to 12. Other books literally are saying 6 to 72 hours, up to 1 week following an inciting event. So you can later have these patients, when you examine, they may have a tachycardia, a tachypnea, or diffuse crackles. And in severe cases, these patients will have confusion, respiratory distress, cyanosis, and may also be diaphoretic. Signs like cough, fever, hemoptysis, not consistent signs. Then when you go to lab work, The non-specific lab work will include, we'll look at the complete blood count, which could show a left shift. The RFTs and LFTs may be deranged, which can show you underlying organ dysfunction. Then the ABG, if you look at the ABG, it will initially show us hypoxemia, which is accompanied by acute respiratory alkalosis with an increase in the AA oxygen gradient. When we get respiratory acidosis, this is a sign of impending respiratory failure. But we can also get a scenario where we get metabolic acidosis, which may point to a metabolic cause of the ARDS like shock. Going forward in investigations, you can also do radiology. Radiological investigations will include X-rays and CT, or even lung ultrasounds. The X-rays will show us lobar consolidation and air bronchograms, which will be important in differentiating if a patient has pneumonia or not, but may not be specific to ARDS. Other investigations can be done depending on where your facility or where you are, or capability of your facility. We can have bronchoscopy and lung biopsy. I tagged a few images to show you what ARDS will look like on a chest radiograph, which here on the left picture, on the left, we see a chest radiograph showing us diffuse bilateral alveolar infiltrates with cardiomegaly in a patient with ARDS. These will be critical in the early stages, so it will be good if you can do a chest radiograph for your patient. So it's still important in ARDS. Then on CT, this patient had ARDS due to sepsis within pneumococcal pneumonia. That's the image. So we then have looked at we have looked at the ARDS looking at clinical features, lab investigation. So I want us to go to histological staging. When you look at ARDS, histopathological stages, we have 3 cardinal stages when you're talking about ARDS. In these stages, you'll have their you'll have the first early exudative stage, or the DAD. You'll have fibroproliferative stage, and then the fibrotic stage. Now, in this graph, we look at a timeline where we have 0. On the x-axis, we have 0 to 14. Those are number of days, and then we have so in the red line will show us the first initial stage occurring. So in the early exudative stage or the DAD, it occurs within 7 to 10 days. And in this, we have non-specific reactions to lung injury, which here will have, this stage will be characterized by interstitial edema, acute and chronic inflammation. There will be type 2 cell hyperplasia, and then hyaline membrane formation. When you go to the fibroproliferative stage, this will occur between 7 to 10 days. So after the 7 to 10 days, we'll get the fibroproliferative stage. This will be characterized by resolution of the pulmonary edema, proliferation of type 2 alveolar cells, squamous metaplasia, interstitial infiltration by myofibroblasts, and early deposition of collagen. So you'll find that some patients can have resolution at this stage, which usually takes about 2 to 3 weeks. But in case a patient progresses to the 3rd stage, this will be the fibrotic stage. In this stage, we'll have obliteration of the lung architecture. We'll have fibrosis and cyst formation. So these changes in the fibrotic stage can range from minimal to severe. So you may find that not all patients get the bad end of the stick. So we go on to look at the clinical course. The first several days in ARDS, like I said at the beginning, it is, when you're looking at ARDS, it is timely to recognize the condition and also intervene as early to prevent the damage from occurring. So first several days of ARDS will be characterized by hypoxemia, which will require moderate to high concentrations of inspired oxygen and a PEEP. So most patients will heal and require less oxygen after this stage. But for those who proceed into the second stage, the proportion is they will have persistent hypoxemia. They will remain ventilator dependent and may also present with when they have these features, this represents a fibroproliferative stage of ARDS. So they tend to have severe hypoxemia, low lung compliancy, they have dead space, and they have progressive pulmonary hypertension. If they survive the second stage, and they will enter into an extended phase of healing. And this stage, there are deficits that occur, which the patients usually remain with. They can remain with deficits of lung function, deficits in cognition. They will have emotional and physical deficits. We then go on to management of ARDS. Remember, when we talked about the risk factors or causative factors, there could be other precipitating factors. So it is important to treat the underlying cause. Conservative fluid management, oxygenation, which can be non-invasive ventilation or lung protective ventilation, prone ventilation, and ECMO. When we're talking of lung protective ventilation, what's to take note of is that we want to have low tidal volumes. You can have 4 to 8 mL per kg of predicted body weight with a target plateau of less than 30 centimeters of water. We want to make sure that the measures we're taking don't actually cause more damage to the patient than they should. So if we look at conservative fluid management, this is based upon an increased risk of pulmonary edema. So we don't want to be very aggressive with our fluid management and end up in sequelae like pulmonary edema. And data suggested improved oxygenation with the conservative approach, despite lack of clear mortality benefit. The fluids of choice are crystalloids such as balanced salt solution. A fluid of choice can be adjusted upon the type of support needed. The goal here is to minimize or eliminate positive fluid balance with the target of, we will target a CVP of less than 4 millimeters of mercury, or if a pulmonary catheter is in place, a pulmonary arterial occlusion pressure of less than 8 millimeters of mercury. But you can also add diuretics. In this slide, we aim to explain a bit about low tidal volume ventilation in patients with acute respiratory distress syndrome. The first step is to know the predicted body weight. So in our setting, we usually use centimeters. So in males, you'll find that the formula you will use for a male will be 50 plus 0.91 into the height in centimeters minus 152.4. You should give you the predicted body weight for a male. For a female, you would use 45.5 plus 0.91 into the height in centimeters minus 152.4. So when we get this, we prefer to set volume assist control, looking at a tidal volume at 6 mL per kg into the predicted body weight. So then the rate of breaths per minute, we should target less than 35 breaths per minute to match a baseline minute ventilation, which will help us avoid hypercapnia. So subsequent tidal volume adjustments, we want to make sure we target a P-plat of less than 30 centimeters of mercury. So you need to check the inspiratory plateau pressure with 0.5 seconds of the inspiratory pause at least every 4 hours and after each change in PEEP or tidal volume. So we'll go on to look at arterial oxygenation and PEEP. You can look at your oxygenation goal looking at partial pressures. We should target our partial pressure of oxygen, arterial oxygen to be between 55 to 80 millimeters of mercury, OSPO2 between 88 to 95. So looking at that, we then can use the FiO2 PEEP combination to achieve the oxygenation goal. The FiO2 will be written in decimals, so 0.3 FiO2 is 30%, 0.4 is 40, and so on until 1. So you find that you can look at that table and then understand that further. So looking at prone positioning. So we have treated the underlying cause. We have looked at fluid management. We have looked at ventilation. Now, when it's good to prone the patient if possible, but there are contraindications to proning the patient. The absolute contraindication would be if a patient has spine instability or patient is at risk of it, or they have unstable fractures of facial or on the pelvic area. They have anterior bands or open wounds, unstable shock, a recent tracheal surgery, or raised ICP. Relative contraindications, hemodynamic instability, due to life-threatening arrhythmias, ventricular assist devices, recent thoracic or abdominal surgeries, or difficult intubation. You can attempt to prone. Other management strategies, you can neuromuscular blockage, inhaled prostaglandins like prostacyclin, use of glucocorticoid, especially in the first 14 days. And then in children, you can use surfactant. Supportive management will include sedation, hemodynamic monitoring, nutrition support, prevention of nosocomial infections, VTE prophylaxis, managed fevers, blood product transfusion, stress ulcer prophylaxis. Among the differential diagnoses, when you're dealing with ARDS, you have to, the number one thing that you need to rule out is acute cardiogenic pulmonary edema, which is quite difficult to distinguish in the late stages, but can be distinguished in the early stages. You should rule out a pneumonia. So your chest X-ray comes in handy. Diffuse alveolar hemorrhage, disseminated malignancy, inflammatory autoimmune conditions like acute eosinophilic pneumonia, pulmonary vasculitis, acute interstitial pneumonia, or the Harman-Rich syndrome, or other forms of non-cardiogenic pulmonary edema, which can be neurogenic in patients who have traumatic brain injury, high altitude pulmonary edema. So you need to ask about history of recent travel while at high altitude. If it can be reperfusion pulmonary edema, it can be re-expansion pulmonary edema in case there's a chest tube for pleural drainage. It can be uremic lung in case the patient has AKI, or capillary leak syndrome. And also we can have negative pressure pulmonary edema in cases where we have forced extubations. So among the complications, these we divide them into are they due to mechanical ventilation or are they due to critical illness? Mechanical ventilation, as much as it's a good maneuver that helps us in manage our patients, we can have barotrauma associated with mechanical ventilation. We can have nosocomial infections, Most commonly here we have ventilator VAP associated pneumonia. We can also have critical care neuromyopathies or sleep disturbances. Then the other complications that can occur due to the critical illness, the patients develop delirium, they can have DVT, they can have GI bleeding due to stress ulceration, and they can also have poor nutrition if you haven't catered for the nutrition. So the references I used to prepare this presentation are as follows. Thank you for listening. I also attached this algorithm for your consumption. Back to you, Dr. Erasmus.
Apologies for the glitch. I had a bit of connectivity challenges. So thank you so much, Dr. Daniel Waiswa, for this presentation. We're kind of running behind on our time, so we're going to have a brief Q&A in this presentation and maybe some additions. So Dr. Preach asked on the chat, at the bedside, which ventilator parameter can guide you to speculate the stage of RDS one is in? It's not an absolute parameter, but one that can tell you how stiff the lungs are. And the hint is that you should not, you should exclude FiO2, exclude PEEP, exclude pressure support. So, Dr. Weiss, what do you think? Is Dr. Weiss still on? Hello? Dr. Weiss, can you hear me? Sorry, some connectivity issues. So, yeah, Dr. Weiswa, there's a question from Dr. Preach. I don't know if you responded to it when I was out, but he wanted to know which parameter it is that we can use to monitor the stage at which the patient might be in the ARDS disease spectrum. And then we have got another question: in an ambiguous clinical situation or presentation, what are the most reliable early warning signs of ARDS that I can differentiate from other causes of ARDS? That is a question from Dr. Keitesi Halima. Dr. Waiswa, might you have answers to this? Okay, I'll just take it. I'll just try to make some general comments quickly. One is for the question that Dr. Preach asked. Definitely, the big thing you want to look at. I meant this, Dr. Preach, might you want to just jump in on that?
Yes, thank you, Dr. Erasmus, and thank you, Dr. Waiswa, for the presentation. So yes, as you have seen in the spectrum of ARDS, from the exudative stage right to fibrosis, the dynamic compliance, which you can get from the ventilator, can be very helpful. And the reason to put that in mind, not to preempt the next presentation, but at the stage of fibrosis, your dynamic compliance is literally in the teens, can be even 10 or 12 or even single digits. And at that point, if you consider to prone the patient, there may not be a lot of benefit. Yeah. So just it's a parameter which I'm not sure we look at most times, but just have a look at it, especially when you decide, okay, we're going to prone the patient. Just have a look at it because it means the lungs are quite stiff. And if the lungs are stiff, even if you prone, you may not be able to recruit already stiff fibrosed lungs. So just keep an eye on the dynamic compliance as you take care of patients. Thank you.
Excellent. Thank you very much. Now, interestingly, there was an argument driven by the late father of ARDS care, Gattinoni, that perhaps patients should not be prone just because they're hypoxemic. Maybe patients who are on ventilation should just be prone, regardless of the etiology, just because of some of the values, some of the advantages we're going to hear from the final presentation of the day regarding prone ventilation. And maybe the fact that we are waiting for a patient to be refractory in terms of the of ventilation, maybe it's already too late for some patients and they are going out with exit wounds or scars and whatever it is, and yet maybe prone ventilation much earlier would have changed things. Then regarding the part of how to differentiate ARDS from other causes, this is a very good question. It's quite difficult, but one thing I guess I want to first highlight here, Dr. Keitesi, is that ARDS is not a disease. ARDS is a syndrome. It is a clinical entity that we piece together based on, it's an arbitrary condition that we decide to develop for ease of communication. Just like we say AIDS, just like we say sepsis. And so we say ARDS as well for a condition, any condition that causes a progressive inflammation of the lungs with disruption of the respiratory membrane and profound hypoxemia as a result, which is not being caused by left heart disease. So essentially, you're looking at any etiology that could cause hypoxemia through damage to the respiratory membrane, happening in this particular patient who's presenting with hypoxemia without evidence of left ventricular dysfunction. So that's the first step is really to rule out left ventricular dysfunction in a hypoxemic patient with clear evidence of ongoing lung injury. So maybe it's trauma, maybe it's aspiration, maybe it's near drowning, maybe it is an infectious cause, could be viral, bacterial, maybe it's a non-infectious cause like an autoimmune disease. And so you have this condition that could potentially cause damage to the respiratory surfaces. And the patient comes to you with hypoxemia, and then you can grade based on the severity after ruling out cardiovascular disease. So you need to know what parameters to look at which can rule out left ventricular dysfunction in the patient. For example, it could be in cold shock, maybe the venous pressures are on the high side, which can also be confusing in patients already having right ventricular dysfunction as a result of severe ARDS. But quite in most patients, initial presentation, it may not be a significant thing. So if the JVP is prominent, patient's left ventricle on examination is clearly in failure, then it might cast a bit of doubt on the underlying issue. Now, just diagnosing ARD is not the end of it. You must proceed to diagnose the underlying disease entity that has led to ARDS, because that disease entity might have specific treatment. For example, it could be viral, which might need some antiviral therapies or antibody therapies, immunologic therapies. It could be bacterial, which might need special antibiotics. Maybe it is autoimmune, among other things. So it's just to help here. ARDS is, for the lack of a better word, an arbitrary diagnostic entity meant to harmonize our communication around the worst complication of alveolar disease that leads to hypoxemia. All right, thank you. Right, so what we're going to do next is we're going to have a back-to-back presentations, because they are all relevant to the same aspect, which is the management of patients with hypoxemic respiratory failure. So right on our screens is a screen shared by Dr. Sophia Menya. That is on a physiological approach to management of hypoxemic respiratory failure. She will take 20 minutes, and right after her, we shall welcome Dr. Faith Komagung, who is an emergency physician, who will take us through prone ventilation. So over to you, Dr. Sophia. And as before, let's mute our mics and share our questions in the chat. And occasionally we shall choose somebody to speak. Thank you. Over to you, Menya.
Good evening, guys. Am I audible?
Loud and clear, Dr. Sophia. Please proceed.
So thank you for the opportunity. Mine is going to be more of a repeat of what we've gone through last week and a bit of what Daniel has just passed us through. So my topic was physiological approach to management of hypoxemic respiratory failure. And we are going to dive in right away. So respiratory failure is defined as a syndrome in which the respiratory system fails to carry out its primary function, that is exchange gases, that is to either oxygenate or eliminate carbon dioxide. It is grossly categorized into two classes, and type 1, which is the hypoxemic failure, it's purely defined as respiratory failure, but with our partial pressures of oxygen, partial pressures of arterial oxygen less than 60. Some books may say 80, but more leaning towards 60. And then type 2 is the hypocapnic respiratory failure, which is characterized by an arterial partial oxygen of CO2 of greater than 50 millimeters of mercury. So we have different causes of respiratory failure, and they can be characterized, like earlier said, we have an infectious process, and in the infectious processes we have pneumonia, we can have extrapulmonary sepsis, maybe like in a pancreatitis, or we can have septic shock. In the non-infectious, you may have aspiration pneumonitis, you may have a TRALI because of blood transfusions that we usually give either in the ICU or even in the OR. Where someone may be having polytrauma, and because of the inflammatory processes that go on because of the polytrauma, you may get respiratory failure. Someone may be having a pulmonary contusion secondary to trauma. You may have inhalational injury and a drug overdose. In drug overdoses, we have things like benzodiazepines, opioids, or even anesthetic drugs like maybe a neuromuscular blockade, which is inadequately reversed. So hypoxic respiratory failure is failure of the respiratory system to perform its gaseous exchange, and it's characterized by an arterial oxygen value of less than 60 millimeters of mercury. In this situation, you may have your PSCO2 as a normal value, or it may be elevated. And at some point, you may have a picture that is having both. You have a PSCO2 greater than 50, but you're also hypoxemic with a PO2 of less than 60. So we'll drive right away into the management. For any illness, our standard approach should be ABCD. We should ensure our airway is patent, patient is breathing, our circulatory system is functional, we've taken off samples, we've had IV access, and their GCS is, say, adequate, their sugars are well controlled, and we expose the patient to ensure everything has been ruled out, or features that show us maybe someone could be at risk of a pulmonary contusion. So oftentimes when someone is in the ICU, they will allow you time to optimize them prior to you initiating your mechanical ventilation. Can be either invasive positive pressure or an IV. So in this instance, if a patient, let's say, was at the ED, a medical patient, and they had aspirated maybe a day or some hours ago, they've been like that, they've been hypoxic for a while, but they are compensating for this. So most times we may want to rush to put the tube down the throat, start invasive mechanical ventilation. But when we do that, we tend to get into compromise, especially hemodynamically. So the current practice is optimize your patient prior to initiation of mechanical ventilation. The other thing to do is to always treat the underlying cause of the respiratory failure, okay? Other than just the symptoms. Someone can be hypoxic, but if we're not managing the pneumonia, we shall continue to be hypoxic because we're not giving the adequate or the right antibiotics, antivirals, or antifungals, okay? So then the other issue that we will do is supportive management and housekeeping protocols in the ICU. Initiate feeding early, make sure your patient is not in pain, they are adequately sedated. We want to use the lowest doses of sedation and analgesia, but enabling the patient to be comfortable. You want to initiate your VTE prophylaxis, ulcer prophylaxis, and the rest, okay? So in our airway, you want to ensure patency, and in ensuring patency, you can use airway adjuncts like OPAs or NPAs. And you can suction the secretions orally, and you remove any foreign bodies if you can see any, okay? So in the next slide, we see our airway adjuncts that we can use. On my left, you have OPAs, and on the right, you have the nasopharyngeal airways. So these are things that should be readily available for us to be able to use, because somehow they buy us time while we are optimizing our patients before we initiate invasive mechanical ventilation. Breathing. If the patient is apneic, you support their breathing with a BMV, administer high flow oxygen, assess their breathing, their rate, their quality of breath, and if they are using any accessory muscles of respiration, and attach monitors. You want to know the values that you're working with, your SpO2 at this level, okay? Some of these are the different oxygen delivery devices that we can use that are readily available. Nasal prongs usually give a flow of 1 to 6 liters per minute, and it can give you an FiO2 of about 25 to 40%. You have face masks, a simple face mask, which give at 5 to 10 liters, and the FiO2 increases to like 40 to 60%. You have a non-rebreather, which you give at 12 to 15 breaths, 15 liters per minute, and it gives you almost 95%, up to 95% of FiO2. You can have a Venturi, which will also give you about an FiO2 of 24 to 60%, and a high-flow nasal cannula, that is if it's available at your facility, and it can give you an FiO2 of up to 100%. In circulation, you obviously want to control for any life-threatening hemorrhage. You want to know if there's a pulse, and if it's not present, you call for help and start CPR. You want to know their cup refill, their blood pressures at that moment, and the warmth of their peripheries. Are they mottled? Are they in shock or not? And in the circulation, you also want to ensure you have IV access and take off blood samples. You want to run your baselines, and at that moment, if you're in a facility that can do blood gas monitoring, you can take off your blood gas at that moment. Take off also cultures, because like we saw, you have infectious causes for respiratory failure. In the disability, you want to assess their neurological status, their GCS. You find that their GCS is less than 8, that means this patient cannot protect their airway. You want to protect it for them, so you intubate. You want to know their pupil size. Are they like that because maybe they have a massive bleed? Are they equal? Does the patient have an scoria? And their random blood sugar. Is it DKA? Is it hypoglycemia? Is it just hyperglycemia? So you want all that. Then for exposure, you want to be able to know any potential injuries. Like I've said, in one of the other causes, you have polytrauma. And if you have, let's say, blunt chest trauma, or maybe a flail chest or something, it shows you that someone could be having a pulmonary contusion. Or if someone had, let's say, a chest drain and it's kinked, when you expose the patient, you will be able to see some of these. Okay, so we have non-ventilator management of respiratory failure. This management is going to be more like an ARDS one, because most of the patients with respiratory failure tend to dwindle down into ARDS. So we have oxygen therapy, and you want it at high flows or an FiO2 of 100%, and then you can start to taper down depending on their response towards that. There are other non-ventilator management that have been proposed, and over time, maybe their purpose in this management has been either supported or not supported. So surfactant, theoretically, surfactant would improve oxygenation. However, there's no reduction in mortality for when used. And the other issue with it is about its distribution towards where it's supposed to be able to work, okay, to the alveoli, okay? So that's why it's not really being used currently. Then you have things like inhaled nitric oxide, inhaled prostacyclin, statins, beta receptor agonist, granulocyte, colony stimulating factors, interferon beta 1A, and neuromuscular blockers. So all these have pros and cons, and most of them have been taken out of the picture. Neuromuscular blockade, there was a research that was done, and there was an improvement in the days of ventilator for those that used the neuromuscular blockade, and compared to those that received a placebo. However, there was not marked difference in the ventilator-induced lung injury between the two classes. So some people will be pro, and then some people will not be pro. And the other conflict is when to actually initiate the neuromuscular blockade and for how long. Fluid management, like previously said by Daniel, you want to be a little bit restrictive because you already have leaky pulmonary capillaries. So you want to avoid a positive fluid balance. Then the other thing that we can do is prone positioning. So about the corticosteroids, this is a table that's from Marino's ICU book, and it's just telling us what kind of corticosteroids we should use, how often, and the doses. So from the different research for COVID-19 patients that have any of the following, you have oxygen therapy, and someone is having NIV or IPPV, you want to give them dexamethasone, either IV or oral, of about 6 milligrams for about 10 days, okay? Then for ARDS, that is moderate to severe, in the first 72 hours after onset, there's two regimens for the methylprednisolone. So the first regimen is 1 milligram per kg of their person's ideal body weight, so you need to know someone's height, and then you taper it down over the 14 days. The other regimen is at 2 milligrams per kg of the ideal body weight. However, you're starting this regimen 7 to 14 days after onset. And this second regimen is just aiming at the fibroproliferative state of ARDS, as discussed earlier by Daniel, so that someone does not get into the fibrosis because it could be irreversible. So prone positioning, I don't want to preempt the next presenter, but this is on my left, my extreme left, you find there's a lady with a bed that is automated. So that bed can rotate 180 degrees and the patient is prone. It's automatic. Then for most of us in our country here, we are yet to get such beds, but we have normal beds. We can makeshift a prone bed. So usually you want to put some pillows so that you have a free abdomen, so that you don't restrict someone's breathing. You put a pillow under their chest, the pelvis, and also support their feet. So this helps so that the patient can be able to breathe very well while they're in the prone position. So an indication for prone positioning is, so earlier it was stipulated that prone position was for patients that were only patients that were intubated. But because of COVID and the practice that followed after COVID, even those that are spontaneously breathing, we are proning them currently. So usually you want to prevent intubations for those that are breathing spontaneously but are requiring high oxygen and maybe NIV. And then you also want to promote survival in those that are having moderate to severe ARDS. So like earlier said, these are the contraindications, they're absolute. If you have active hemorrhage, you don't want to prone your patient. If you have any spinal instability, you do not want to prone your patient. If you have multiple fractures, do not prone the patient. If you have increased intracranial pressures, don't prone. And then if you have a recent tracheostomy or sternotomy that is less than 2 weeks, you do not want to prone this patient because you have a risk of decannulation or even injury to the sternotomy wound. Okay, so it is stipulated that proning for the patients that are breathing spontaneously, it should last maybe around 8 hours, and then those for the patients that are intubated, you want them to last about 16 hours, and then you change them back, and then you can reassess. If there is improvement in their PaO2 following the first episode of proning, and this improvement lasts and continues for more than 4 hours, it is said that you do not need to prone these patients further. But if even after 4 hours following the first proning event, there's, let's say, deterioration or no improvement, you continue to prone them. Okay, so then we go to NIV. This is most of the time now more readily available as compared to before the COVID times. And for most hospitals, I think we can do NIV. Most times because we have mask, it's NIV with a mask. So this is just a graph to show us the failure rate of NIV. The failure rate is less when you have mild ARDS, and with a difference of about 5% between moderate and severe. Okay, so you need to be monitoring patients that are on NIV because their failure rate is a little on the higher side. Okay, then the hospital mortality is much reduced when you have successful NIV as compared to a failed NIV. All right. So while we have patients on these non-invasive ventilators, we need to be monitoring them a lot more adequate and intervene in time, especially if there's no improvement. Either the work of breathing has remained the same, or has worsened, or their mentation has been altered. Intervene in time so that you try and improve their mortality. Okay, so mechanical ventilation. Before we ventilate these patients invasively, you want to know about the things that mechanical ventilation can do, or even the disease process of the respiratory failure or ARDS. So there's a concept of patient self-induced lung injury, and this is a phenomenon that is usually currently being stipulated that when the patient is in distress, they have varying intrathoracic pressures and their tidal volumes are quite high. So because of this varying intrathoracic pressures, there is a failure to transmit this pressure to the blood vessels within the thorax. And because of that, you find that there is leakage there's leakage through the vessels into the lungs. And when you couple this with the pathophysiology of ARDS that already has leaky capillaries, you find that there is going to be a lot more edema. So you need to put it at the back of your mind that already the patient has been laboring with an increased work of breathing, so they already have the patient self-induced lung injury. Then you have the pathophysiology of the ARDS that is giving you leaky capillaries. And then because of our ventilators, you may have ventilator-induced lung injury. So we have volutrauma, atelic trauma, and biotrauma. Biotrauma is majorly because of the pressures that we are using to inflate this lung. And because of these pressures, they cause inflammatory markers to be produced, and this gives us cytokines being produced, and then we have a systemic inflammatory process going on. For the atelic trauma, because the lung is stiff, for every breath that is given, you find that the small airways, that is the alveoli, will keep closing. So because of that sheerness and cyclical process of giving a breath and then it closes, you find that you have atelic trauma and the volutrauma. The volutrauma is mainly because we are giving so much volume for a lung that is almost at 50% capacity or less. So you tend to cause trauma to it. So while we intubate these patients, you want to be protective. You want to protect their lungs. So in your first stage, you obviously want to know the patient's height because it's going to guide you on getting their ideal body weight. So you set your initial tidal volume at about 8 mL per kg of their ideal body weight. You can choose any mode of ventilation. There's no preference to either pressure or volume. You can choose any, okay? So then you add a PEEP of about 5, and select the lowest FiO2 that achieves an SPO2 of about 88 to 95%. And then after you've achieved this, you start to reduce your tidal volumes by 1 ml per kg for every 2 hours until your tidal volumes are at about 6 ml per kg. And with this, it is said your lung is not very over distended. So your second stage, when you have reached the 6 ml per kg, you want to measure your plateau pressures. And the plateau pressures is more of the pressure within the airway that at that point the lung is fully distended. So if your plateau pressure is greater than 30, you want to decrease your tidal volumes in 1 ml per kg increments until your plateau pressures are less than 30, or until your tidal volumes are about 4 ml per kg. So in your third stage, you want to monitor the blood gases for respiratory acidosis. So if your pH is, let's say, 7.15 to 7.3, you want to increase your rate to blow off the CO2. And then if your pH is less than 7.15, still increase your rate. You can also increase your tidal volumes until your pH is greater than 7.15. So in lung protective ventilation, we have what we call permissive hypercapnia. So research has been done, and it is said that at a PSCO2 of, let's say, maybe 50 to 60, as long as your pH is greater than 7.3 or 7.2, a person can survive. So in this, because we're using very small tidal volumes, you want to allow for hypercapnia. So that is the permissive hypercapnia. And then your optimal goals for lung protective ventilation is 6 ml per kg, a plateau pressure of less than 30, an SPO2 of about 88 to 95, and a pH of 7.3 to 7.45. So this is a table to show us a guide of the FiO2 and the PIPs. It is hard for me to use this table, and I do not know if the faculty on the call actually use this table. Maybe Dr. Erasmus will give us his take on this at when we're having a Q&A session. But it's a guide that at this FiO2, I want a PIP of this. If I have this, like that, it's just a guide. So another form of mechanical ventilation is APRV, which is airway pressure release ventilation. And this kind of mode of ventilation gained a lot of momentum or fame during COVID. So for this mode, you allow spontaneous breathing at an airway pressure of about 30. So it is stipulated that from about 25 to 30, the lung is fully expanded. So that is why they chose the upper limit of 30. So the person breathes for quite a while they're at an airway pressure of 30, and then you release. You have a low pressure that is usually set at 5, and this allows for CO2 elimination, and then it goes back to the high pressure, and then like that. So the low pressures is when you're allowing for CO2 elimination. Okay. Not very many of us have used this. Maybe we'll get experiences from those that have used it, and they tell us the difference between this and the lung protective ventilation. To continue the talk, death is usually not because of hypoxia or hypoxemia or the ARDS itself when you have respiratory failure, but it's because of multiple organ failure. So if the more organs that you have failing, the more the mortality. So, like we said earlier, you want to support these people and support all organs. And like in the case that was presented by Emu, we saw that they supported the renal system by dialysis, and the patient was able to be discharged home. Okay. So there's also the extracorporeal life support, and it's usually considered for when hypoxemia is refractory to mechanical ventilation and prone positioning. We unfortunately don't have so many places that can offer this. Maybe UHI using their bypass machine. And I do not know much about this, but we are going to have a discussion about it next week by Dr. Claire. So please tune in next week. So in conclusion, we always want to treat the underlying cause. And like we said, there is no specific treatment for ARDS. We want to support them, support all systems, rest the lungs, while we manage the underlying cause. And like I said, the principal cause of death in ARDS is multi-organ failure, with a very few exceptions of like COVID. I think in COVID, there was mortality because of hypoxia. So thank you. I will stop sharing so that Faith can share.
Perfectly done. Thank you very, very much. It's a broad topic, and we needed you, because we know your strength in this, to put it all together and just help us go through, the approach to a patient, right from the mild to severe hypoxemia. So let's just have Dr. Komagum take us through the cardiorespiratory effects of prone ventilation quickly, and then we shall have questions to this. Kindly keep posting your questions in the chat. I'm noting all of them. Then we shall tackle them when the question and answer session is open. Thank you. Over to you.
All right, thank you, Dr. Erasmus. Thank you, Sophia, for the presentation. Mine is going to be really brief and quite specific, the cardiorespiratory effects of prone ventilation. This is just a brief outline of what we are going to discuss. So traditionally, invasive mechanical ventilation has been delivered in the supine position. However, prone ventilation is that ventilation which is delivered with the patient lying in the prone position that Sophia already described in her previous talk. So over the past 2 decades, there have been several RCTs that have demonstrated improved oxygenation when patients are, particularly ARDS patients, are ventilated in this position. And following that, subsequent meta-analysis have also shown mortality reductions in patients, specifically with moderate to severe ARDS, when proning is done early and for a prolonged period of time. So the largest of these RCTs has been the Perceiver trial, which is prone positioning in severe ARDS. You are all, I advise everyone to just have a look at that paper and see what the findings are. And there have also been several other meta-analyses that you will see in my references later. And based on these trials and meta-analysis, there have been a number of societies that have recommended proning in their management guidelines for moderate to severe ARDS. So now looking at the mechanisms of physiology of prone ventilation, it can be summarized into these brief points, which I will then go into one by one. Starting with the first mechanism that improves oxygenation. I mean, they're multifactorial, but we'll start with particularly the reduction in ventrodorsal transpulmonary pressure difference. So now I'll go into explaining what this means exactly. So I'll show you this picture on the left. And so the transpulmonary difference is, you just basically can understand it as the distending pressure. And so it is the formula basically is the pressure within the alveoli, i.e. the airway pressure minus the pleural pressure. So when someone is in the supine position, as you can see here, you'll find that on the ventral aspect, which is the dorsal side, there is a rigid bed, while on the dorsal aspect, which is posterior, there is a rigid sort of bed, and we also have the excess wet lung that weight further adding downward pressure, while on the ventral aspect, which is the superior side, we don't have those limitations. So what happens is that on the ventral aspect, you will have a higher transpulmonary pressure, and therefore it will be greatly distended compared to the posterior aspect. So because of this, you will have the alveoli on the ventral side hyperinflated, while the ones on the posterior side are atelectatic and quite compressed. So because of this, the lung is then prone to ventilator-induced lung injury. While in the prone position, if you look at the picture that's below that, we have the dorsal side now not limited by the excess weight of the lung that is edematous and wet, and also we don't have that restriction of the rigid bed. So what happens is that the dorsal side will now have a greater transpulmonary pressure, and therefore you will have a more homogeneous expansion of the alveoli, which essentially will reduce the complication of ventilator-induced lung injury, but then it will also improve oxygenation, and it will also encourage recruitment of the previously atelectatic alveoli. So that is the first mechanism, which is a reduction in the transpulmonary pressure difference. Secondly, you have reduction in lung compression by the heart and abdominal contents. And so I'm going to just explain how this results into improved ventilation, still using this image here on the right. So as you can see here on the left is the supine position, where you'll see that you have the heart, and below that you have the abdominal contents causing compression of the diaphragm into the lung as well. So due to this excess weight and compression, you will have limitations with compliance, and therefore there will be inadequate ventilation. While in the prone position, this is reversed. So you find that the heart and all that weight is transferred to the bottom, and you also don't have the abdominal contents causing compression. And in that way, you have there's reduced restriction to your chest wall movement, and that also results in improved ventilation and subsequently improved oxygenation as well. So the other point is improved perfusion, which also results in improved VQ matching. And I'm going to also explain this using a diagram. So essentially, blood flow in the lung is more towards the dorsal aspect than the ventral aspect. So in a situation where a patient is lying supine, you'll find that the dorsal aspect, as we saw earlier, you have your alveoli atelectatic, while the ventral aspect, which is actually not receiving as much blood supply, is the one that has well aerated alveoli. So because of this, there is going to be shunting, i.e. there's perfusion more to the areas that are not being well ventilated. So if your patient is turned into the prone position, you still have preferential perfusion towards the dorsal aspects of the lung. However, we had already mentioned that you have recruitment of alveoli, and also now the distension of the alveoli is more homogeneous. So in this way, there is improved VQ matching, and there is also reduced shunting, and this improves oxygenation as well. The other mechanism is also there's going to be increase in cardiac output, particularly from the right ventricular side. As we know, the lung usually compensates for when the lung is maybe in a situation where you have poor oxygenation, then there's going to be compensatory hypoxemic vasoconstriction, right? However, if now you've proned your patient, so essentially you have your alveoli homogeneously distended and you have improved oxygenation, that essentially will mean that you have reduction in the hypoxic vasoconstriction, and that subsequently also reduces your your pressures, your intrapulmonary pressures. So that reduction in pulmonary vascular resistance will then reduce your right ventricular afterload and also increase your right ventricular preload. So in that way, you're going to have improvement in your cardiac output. So those are the main mechanisms by which proning is going to affect your oxygenation. So this table basically summarizes what I've just said. Maybe the one other thing that it will also improve is secretion mobilization. This is still a summary, categorizing them into the respiratory effects of prone ventilation, and on the right side, you have the cardiac effects of prone ventilation. So I will not repeat what I just said. So just take away from what we've discussed so far. The important thing to note is that prone ventilation is going to significantly improve oxygenation and reduce mortality in moderate to severe ARDS. And also, cardiorespiratory effects of prone ventilation, in summary, include the beta VQ, matching, reduced ventilator-induced lung injury, and also there's going to be modulation of cardiac function with improvement. These are the references. Particularly of interest is this third reference, which is the Perceiver trial. So you could go through that, but I've also included some of the meta-analysis that might be useful for everyone. That's it from me, thank you.
Lovely, lovely, lovely. Thank you very, very much for that great presentation. Kindly, team, continue adding questions to the chat. So we're going to tackle some of the questions that have been sent. And these questions, for Dr. Sophia, and some will probably follow on Dr. Faith's side as well. So I see on the chat, Dr. Sophia has already responded to Rich's question. Why would a severely anemic patient saturating at 100% SpO2 still be hypoxemic? Since we're discussing physiology. Dr. Sophia, I see the answer you gave, but could you just unmute and give us an explanation?
I'm unmuted. Sorry. I would think because of the oxygen delivery equation, which states, okay, which has these parameters. So you have an SaO2, the HB, and the PaO2, okay, multiplied by a constant. So despite having a good saturation with an HB that is low, your PaO2 is expected to be low because of the oxygen carrying capacity of the hemoglobin.
All right. I guess maybe just a correction on the question is that would be necessarily hypoxemic should be hypoxic. Why would a severely anemic patient saturating at 100% SpO2 still be hypoxic? Basically, hypoxia is different from hypoxemia, and that's something key. I think the previous presenter on that topic really tried to stress it. Hypoxemia is an emia, that means the saturation of oxygen or in blood, and then the hypoxia is to do with the tissues. So you can definitely have a good saturation of oxygen, but your tissues lack oxygen because you have inadequate oxygen carrying capacity as described by Dr. Sophia. In the last week, the Hafner's constant was mentioned as either 1.34 or 1.39, and I just need us to understand why that happens. Dr. Sophia, might you have an idea why the Hafner's constant is 1.39 or 1.34? In the calculation of the content of arterial oxygen. Dr. Sophia?
it will come from far.
Okay, so
But
basically,
the previous presenter can help us. Maybe, was it Sophia?
I don't see her. Sophia is here, right? Yeah, Sophia Namuviru, why would you, in some situations, consider 1.39 and in some consider 1.34, and what is used in calculations of oxygen?
Doctor, so what I remember, what I had read is the Hafner's constant is the amount of oxygen that can bind to 1 gram of hemoglobin.
Yes, so why is it considered as 1.39 or 1.34? Why the difference in the two figures? That's a big gap, big difference.
Oh, I think it depends the presence of like abnormal hemoglobin.
Okay, that's great. That's great. So what happens is that in pure hemoglobin, the capacity to carry oxygen is about 1.39 milliliters per gram of hemoglobin. But when the patient, as we live our lives, we are eating some silly things. Some of you guys have seen you carrying toxic things for lunch. And also the environment we live in has a lot of impurities in the air, like carbon monoxide. Other things that we take into our bodies can oxidize our hemoglobin to methemoglobin. Then you can also have silk hemoglobin as other abnormal hemoglobin that will never carry oxygen. So in terms of being realistic, the lower Hafner's constant is considered in the calculations, considering a possibility that you have those other abnormal hemoglobin that can never participate in carrying oxygen. So that's really why there's a difference. So yeah, so you can be hypoxic when you have a good saturation. Okay, so next question here is Dr. Sophie again. During ventilation, do we target PCO2 or pH? Which one is better to target of these two during mechanical ventilation?
During mechanical ventilation? In ARDS?
Well, lung protective ventilation, I guess. Is this
Okay.
you mentioned?
So we are targeting pH.
Okay. All right, so that's really key
because
for everybody to.
Hypercapnic. Because there's an allowance for hypercapnic, for what? An increased PSCO2.
Yeah, so that is really key for everybody to note. I've got patients where the PCO2 is down to the 20s, and the doctor is about to get a seizure because they fear the patient is going to get brain ischemia. You know, so you ventilate patients with a pH because the pH that's going to affect the cells of the body, and also the vascular tone is kind of affected indirectly by the pH or directly by the pH. So a PCO2 is a contributory volatile acid that helps us to adjust the pH conditions of the body, and we must use it. So when we're talking about lung permissive hypercapnia, we need to know that there is a limit to which the PCO2 now becomes toxic to the patient. And this particular patient that was presented by Dr. Emo was on what should be termed, ARDS net ventilation settings, where they were on a high PEEP, on a low tidal volume, on permissive hypercapnia, and the numbers looked quite fair to at the time, but then the PCO2 was climbing, pH was dropping drastically, and the patient was going into profound shock, RV failure, hence AKI shock and other things. So the simple change was to determine that we're probably too much onto the permissive side, and the CO2 was way beyond what is supporting the pH of the patient, and adjust the ventilation alone helped to restore perfusion, improve renal perfusion, and eventually get a patient out of trouble. So remember that. So I guess this one is the next question I have on the chat is philosophical, and perhaps I will call in an intensivist here. Dr. Preach, I guess I will need your services here. Regarding lung protective ventilation, what do we actually in clinical practice call lung protective ventilation? I have my philosophical answer. I just need to get another doctor's opinion.
Thank you for that question. Indeed, it is lung protective ventilation, it's quite philosophical. So it depends on the patient you're dealing with, but then it also depends with the underlying pathology. For example, if you're talking about lung protective ventilation in, let's say, a 70-year-old patient with infective exacerbation of COPD, came in intubated, and the reason for intubation was, let's say, type 2 hypoxemic respiratory failure with a TCO2 of, let's say, 70, and then also has ARDS, let's say, from a pneumonic process. Now, the lung protective ventilation for that patient, if you compare that with a patient who is, let's say, 25 years old, has had chest trauma, has pulmonary contusions, and you're with multiple rib fractures, the lung protective ventilation strategy will be different for the two. But I think the ethos behind it is to prevent volutrauma, barotrauma. And that's why there are some general targets. For example, plateau pressure less than 30, driving pressure, I think, less than 15, permissive hypercapnia. But at the end of the day, while knowing the general edifice is important, the bedside patient that you're looking at is very different. For example, the patient with very high carbon dioxide with infective exacerbation of COPD or even severe asthma, their lung protective ventilation is different because in as much as their lungs are injured, they're having bronchospasm, they're having carbon dioxide retention. The permissive hypercapnia for them might be ideal, but might be challenging. For example, at one time we managed a patient with post-cardiac arrest due to severe ARDS, but then also they had a massive pulmonary embolism. Now, the end-tidal carbon dioxide level was, let's say, 2.1, and the blood carbon dioxide level was, let's say, 7 kPa. Now, the difference was very big. It meant that they're having a big shunt. They're not blowing off carbon dioxide. And therefore, for the very first few hours, we had to increase the tidal volume to increase the carbon dioxide elimination. So it is very philosophical, as you said, but the bedside patient will guide you on what to do and constantly re-evaluating and seeing if your interventions are working. Thank you.
Lovely. Thank you very much. So I will grab Dr. Claire too. Claire, just on the same question, Claire Barker. You know, when we talk lung protective ventilation, in terms of lung mechanics, which parameter are we really looking at as more contributory to protect its lung? Dr. Claire, on?
Yeah, I'm on. So you just asked about the parameters to look at when you're doing lung protective ventilation, right? So some already mentioned by Preach. So we look at the tidal volumes. So which are dependent on the ideal body weight. It should be about 4 to 6 mils per kg ideal body weight. And also we look at the we mentioned, Preach also just mentioned about the driving pressures, which should be less than 15, and peak pressures not more than 30. Yeah, basically those.
Right, thank you. You know, why I'm asking this is because, you know, there's all this that we learn, and unfortunately, most of the literature we are dealing with is coming from the Western world, where the guys have so many options to care of these patients. If I have a patient that I'm putting on at the ultra low tidal volume ventilation, and they are getting extremely crazy CO2s, I can put in an I-lung, you know, and clear out carbon dioxide, which is extracorporeal CO2 removal. We shall have a chat about that next week, again, presented by Dr. Claire. Or we may just put them on ECMO and rest the lungs entirely, you know, and that seems to, you know, work for them. But we are in a setting where we don't have these options, you know, as already mentioned by Dr. Sophia. And so the last line of intervention for you is really that ventilator and how to work it. And I guess it comes down to having a number of trade-offs that you might be comfortable accepting versus sustaining certain things. So for me, I feel the priority really is to prevent ventilator-induced or ventilator-associated lung injury, which is the primary thing. So how much volume trauma contributes versus barotrauma, versus biotrauma, atelic trauma is quite difficult to determine. But it appears in the review of the ARDS net data, the data that led to that, that table that Dr. Sophia shared, where they were talking about the FiO2 that's matched to a certain PEEP. In the reanalysis of that data, they found that actually the plateau pressure, the tidal volume, were less contributory. Yes, as they increased, this kind of affected the lung, but they seem not to be the main contributors to injury to the lung. And of course, remember that you can improve the patient's oxygenation, improve the patient's CO2 levels and pH, but the patient will still die, because what contributes to death of the patient is the multi-organ injury that happens from injured lung causing injury to other areas of the body. So the idea of ventilation would be to avoid that kind of worsening injury to the lung that's already sick. And so the driving pressure seemed to be the standout function here. So idea of high PEEP seem to have fizzled out to saying titrate the PEEP to the appropriate compliance at which the patient's lung is operating at its very best. And so it's no longer the idea of putting the PEEP very high as the ARDS net tables were dictating. Similarly, the idea of aiming for low oxygen targets is really more to tell you that, if you can achieve an SpO2 or SaO2 of 88 and above, you're probably safe, because going for 90, 98 and so on might cause you to overventilate the lung and cause more injury to the lung and cause, ventilation lung injury. So we target this, a appreciable oxygen saturation that sustains the patient's life. But remember, of course, that the hemoglobin and the cardiac output must be okay for the patient to deliver enough oxygen to tissues. And so, yeah, so it's kind of confusing, and I'm learning quite a bit as a practitioner in the resource limited setting, where I don't have ECMO and other, extracorporeal interventions to save my patients. And somehow, it's revealing that whatever we have in the guideline-based approaches, as Dr. Pritch mentioned, really needs to be standardized to a patient before you, and you need to continue reading the weather. Remember that you fix your settings of the ventilator at the beginning, but must continue to review them for efficacy in terms of gaseous exchange, but also safety and comfort for the patient. So I feel for me, that's my philosophical approach, really. So I don't really chase the pressures. I chase just the descending pressures as the things that I'm kind of worried about. And I implore everybody, just because I don't have enough time, just to go and look at the information around the stress strain index for the patients, for the body, for the lungs. The stress strain indices exist for every stretchable material. And if you remember Young's modulus in physics, it's kind of derived from that. So the lung has got Young's modulus, and if you factor in a certain complex computation, you find that they extend the lung within the, descending pressure about 15 to 18 might keep the lung a bit safe if the lung is normal. But remember, in ARDS lungs, you already have a very friable lung that's going to be damaged even by that pressure. So as the lower the descending pressures, the better. But of course, sometimes the descending pressure may not be enough to keep the patient alive, because the CO2 will get worse, the oxygen levels will get worse, right ventricle will fail, patient will go in shock, and the patient will die with lung protective ventilation as per the textbook. So I am a preacher for rebellion against the standards from the people of lung protective ventilation. Yeah, Long explanation. Dr. Peter Agaba was trying to clarify that the mode APRV is best referred to as time-controlled adaptive ventilation, TCAV. I would like to invite Dr. Agaba just to make a comment on APRV, just to explain to us how it works and how it helps patients. Dr. Agaba, please. Dr. Peter Agaba.
Hello.
Yes, sir.
I haven't gone anywhere. I'm still here. So what was your question?
Yeah, so I wanted just your input on APRV and how it works and how it can be applied, and maybe how it might differ from the conventional ventilation modes that people used to.
So TCAV is a different way of doing APRV, and the group of people who came up with it were sort of frustrated with the usual maneuvers that we do to open the lung and keep them open, because they found that everything you did, whatever recruitment maneuver, whatever recruitment topic you used, you still lost the whatever you had gained by recruiting. So they decided to try APRV. But if you look at the traditional way of using APRV, you set a time at a high pressure and then you set a time at a low pressure, and you allow the patient to breathe throughout. But the strategy in ARDS is to try and recruit the lungs, and the idea with TCAV is to provide a continuous pressure for the lung to just keep it open, and as you keep the pressure up, even the alveoli that are still collapsed will eventually open up. So what they do is they use the lungs mechanics and time to keep the lung open. So they will spend a longer time at a high pressure. They won't set any PEEP. So for the time at a low pressure, the low pressure is actually 0. And like Sophia had shown in that diagram that she had, the pressure, the high pressure was 30. So you set a longer time at 30, and you set a shorter time at the 0 pressure. But the time at the 0 pressure is set in such a way that the lung never empties completely. And that allows you to avoid complete collapse, which would risk more injury from the strain and stress and the shear that comes from lung units opening and closing. Yeah. So in a nutshell, that's what TCAV is. You don't set the vent the traditional way you do with APRV. You set it differently, and then you watch the lung, and you make adjustments based on what you see with the lung. So if you have got really good flow and time diagrams, you can adjust your vent settings better. Difficult to explain on Zoom, but that's what I would say.
Yeah. So if you are doing this, what would be your biggest concerns, and what should the practitioner watch out for, especially?
Oh, it's a while since I have used this mode. I sort of abandoned it because if not very many people understand it, and there's no point in you practicing it if the people you work with can't do it. But the main thing is to really look at the compliance of the lung. For patients with ARDS, the lung is very stiff, and that means it empties very quickly. So you want to make sure that you avoid the lung being completely emptying. So that time when you decrease the pressure or allow the pressure to drop to 0, you have to shorten it, but you have to set it in such a way that it is you have to watch the peak flows, okay? And what you want is to set it such that the peak flow decreases to a certain point, and then the pressure rises back up again. It's difficult to explain right now, especially because I haven't done it in a long while, but if there's anyone who's interested, I can share with them some literature on how to do it.
Yeah, sure. You can definitely share with us, and we can put it on the forum later on. But I guess the concerns also around APRV, around the pressures that are used, and therefore the mechanical energy that's dissipated on the lung, especially that they are spending quite a long time in a high pressure mode, means that the mechanical energy may be a lot, and so if not well handled, definitely the risk of lung injury can be extreme, especially with the pneumothorax and the like. And of course, that also takes out a part of air trapping. Again, because they spend so much time in high pressure, they may struggle to expire, and that could, in some situations, especially with mucus plugging or reactive airways, may lead to air trapping and eventually pneumothoraces, hypercapnia, among other things. So there are definitely things for the practitioner to watch out for, but it's quite an amazing mode, ideally, to recruit a very horribly consolidated lung, and if it doesn't cause you the complications. But I guess, like Dr. Peter mentioned, since it's new into most people, you would really need quite a good exposure to everybody, so that there's unit practitioners working in sync, because any small adjustment that is not proper could cause a patient trouble. And I think we got quite a bit of a spike in ventilator-induced complications during the COVID pandemic in units where people started practicing APRV for their patients, but without harmonized practices. All right, so we're really well past our time, but I just want to capture some quick questions. Jonathan, as Dr. Sophia, this will be for you. For diabetes ARDS, how do you handle steroids? How do you go about steroids? Dr. Sophia, quick answer here.
The quick answer is it depends on the level of ARDS and what the cause of the ARDS is, surely, because we want to try and treat the underlying cause.
Yeah, so he's asking if
the
patient is diabetic and you want to give steroids, what will you do, given that you also have to give steroids? If you think
I would give it because I have insulin to give for for the hyperglycemia. I would still give it if the patient needs it.
Yeah, so Semakula, I think the short answer definitely is what Dr. Sophia has given. Just give. It's about benefit versus risk administration, and you can always counter the hyperglycemic effect of steroids with insulin. Yes. And then Dr. Faith, would you still prone a patient even with good oxygenation when supine? And if the patient were to arrest in prone position, do you return to supine for CPR? Over to you, Doc.
Thank you. I think Sophia also mentioned earlier on the indications for proning, for prone ventilation. So in that scenario, I would really ask what the rationale is for proning. I think we already looked at the indications. And then for the patient who is in prone and arrest, you cannot do any CPR in a prone position. So in that patient, you have to reverse them to the supine position in order to be able to give good quality chest compression and adequate resuscitation.
Okay, Dr. Agava, have you had a patient arrest in prone? Dr. Agava?
Yes, I have. But we were
we
do
hadn't
you do?
proned the patient to do prone ventilation. We had proned them
Okay.
to operate. We started the CPR with the patient in the prone position. I've had 2 instances, but the first one was a little child. It was easy to start CPR, but eventually both patients were prone and the CPR went ahead. But not with anyone who was on a mechanical ventilator in the ICU.
Noted. And Preach, is Preach still around? Dr. Preach? Or Dr. Claire, have you had to do CPR on a yes?
So I'm around, but I've not yet done CPR in a prone position patient. However, the place where we work, the current practice is if someone is in prone, you just start the CPR in the prone position.
Yeah, so that's quite good information. Yeah, because there's increasing evidence that you can do very good chest compression prone, especially with fairly good transthoracic pressures, which can drive out blood from the heart to perfuse the brain. And also, most times when a patient is prone, when you're going to CPR, you're going to flatten out the bed, which lowers the head, the brain relative to the heart in a way and allows better perfusion of the brain. There's those arguments, unless of course the neck is king. So the practice is that you probably don't have to unprone the patient. The recommendation is that you may not have to unprone the patient, but certainly you have to monitor the parameters of ventilation. In this case, you must be able to look at your end-tidal CO2s to suggest that you're getting good cardiac output during compressions. So yeah, I've done CPR on patients in prone, and we of course we had ROSC in some, we've not had ROSC in others, and the argument has always been, should we unprone? And I guess I've always argued that the patient was always severely hypoxemic in a supine, and that's why we proned them. And so if we were to turn them, we would probably lose that component of good oxygenation, which might be quite a good thing for the ventilation of the patient for CPR. And yet we can still generate quite a strong enough compressive force to drive blood out of the heart. So yes, I do a CPR when patients are prone, if they have been prone, especially for hypoxemia. But yes, I do also know that the practices in ICU must follow the tradition, the unit. So if people are used to doing CPR in supine, then you might have better help for the patient if the patient is supinated as soon as possible. And that also follows the question of do you prone a patient even in good oxygenation? Again, most nurses and doctors are used to seeing the patient's face, and so they suggest patients stay supine unless they are trying to die, from hypoxemia. But the reason for prone ventilation is not for oxygenation. The reason for prone ventilation is to homogenize airway pressures to preserve the lung from shear related injury, and also heterogeneous VQ challenges. And so ideally, dogs walk the way they do. Tortoises live for 150 years for a reason, perhaps because they are prone compared to you who is walking on 2 legs, and then you go to bed, you want to leave your sick sack hanging up. So it appears that proning would ideally be recommended for anybody who is sick and hospitalized, because it helps the lung quite quicker. And that was the argument that Gatineni and team were making before. It's difficult to keep a patient prone when they are awake. Definitely difficult to convince the medical team for a patient who's not severely hypoxemic to keep a patient prone. But there seems to be good scientific basis for proning everybody who's requiring ventilation, because it helps prevent ventilator-associated lung injury by homogenizing airway pressures. Yeah, so that I think that's my take. I don't know if there's anyone with a burning question. I just need to raise their hand. I've seen the question by Dr. Ansereko for whether evidence to appear of this. Maybe for now, I would just recommend that you read a bit more on the subject, and then you can have a conversation, Doctor. Do you have any burning comment We're almost 30 minutes past our usual time. All right, so I just want to conclude today's session. Our mentor for the day could not join us because in another session. We set out to discuss hypoxemic failure. It's a broad topic with multiple facets to it, and hopefully we shall cover some of them as individual topics with time. But this was just a general overview of hypoxemic respiratory failure and how to recognize it and how to intervene. And the idea is that hypoxemia is a leading complication in hospitalized patients. And one of the leading reasons for patients being admitted to ICU. And regarding ARDS, it's important to know that it's not a disease. Whenever we think about such a disease, we shall be trying to diagnose it from a chest X-ray. Chest X-ray will only show you radiological signs. You must integrate them to deduce that this could be ARDS in the patient, in addition to other diagnostic parameters that we'll be taught about today. And ARDS definitely is not a homogeneous disease. It comes in different subphenotypes. And there are different ways to subphenotype ARDS, but ideally there are those that are rapidly proliferative and those that are less proliferative. And so this disease will differ in the lung mechanics that you're going to encounter in caring for them. So the whole idea of throwing high pressures, low tidal volumes to patients must stop. And I bind it in Jesus' name. Because patients are not exactly the same. ARDS is not the same in every patient. So you must determine the patient's specific lung characteristics so you can ration the care you're going to give them. Stage the disease as well so you can get therapies, because there are stages where some drugs, some interventions are relevant, as Dr. Preach mentioned. In some stages may not be relevant to maybe to prone, it may not be helpful anymore. In some stages, giving steroids may be dangerous, among other things. So try to stage the disease and determine what the patient's on, and then treat the underlying cause. In terms of management, the key thing to get a patient out of hypoxemia, or especially to ARDS, is to maintain the lung dry, clean, and understretched. That will preserve the lung, preserve the heart, preserve the distant organs, and avoid multi-organ failure, which is a leading cause of death in these patients. Meanwhile, you continue supporting gaseous exchange to keep the patient alive. Remember, ventilation, oxygenation are a bridge. They're not a cure for ARDS. They are a bridge to sustain the patient long enough for you to treat the underlying cause and get it better. So that is it for today. Thank you so much for tuning in. Next week on the 24th of January, Friday, please join us. We have an interesting topic. There are people who need help because they cannot breathe. So telecolleague, and join us. Thank you and good night. Bye-bye.